Oh. Good morning, everyone. Welcome to the Daily Whatever Show. I am Dana DuBois, and it's Thursday, which means it's Fine Feminist Hour here on the Daily Whatever Show. And we have a very special guest today. I think I can say my friend now,
Yes,
and
I would agree.
one of my very favorite substackers, Dr. Amber Hull. We also have my dog. She's been silent all morning, and as soon as she hears the start, she's now like, "Hey, everyone wants to hear from me."
Yeah, mine are downstairs right now, but they may pipe up a little bit later. So
Oh, good. Maybe we can get them talking to one another,
we love the furry friends.
drowning us out. Dr. Hull, you likely need no introduction for lots of folks on this show. You are the author of excuse me, Under the White Coat. You could hear I'm still getting over my cold, but it is way better this morning. I feel like I have at least 60% of my brain power back, which feels great.
We'll roll with it.
Pardon?
I said we'll roll with it.
We'll roll with it. Please introduce yourself to the folks in the chat and listening live. And I'm going to give my dog one of these tasty treats while you do that.
Excellent. Good morning, everyone. I'm Dr. Amber Hull. My Substack is Under the White Coat. I am a physician based in Vancouver, British Columbia. I left the United States last year, which is a topic of some of my writing. For the most part, I write about human sexuality. I write about women's health. I write about hormones. I write about relationships. I write about kink. I write about immigration. And I was kind of thinking, based on some feedback that I got from some of my readers that I was interacting with yesterday, that really kind of the unifying theme of a lot of what I write about, which seems like disconnected, is really about consent. I write a lot about consent, autonomy, consent in sexuality, consent in relationships, consent in medicine, both, as a physician and as a patient, and what informed consent looks like. And also, to a degree, the consent of the governed, as it pertains to immigration and sort of what one allows themselves to be subjected to. Although I will be cautious to say I don't politics isn't my topic, primarily because it's just so heavy right now. And I feel like both for the sake of myself and my readers, they kind of want to break from some of that stuff. So I tend to write about sex and medicine.
I love a good narrative arc, and the way you just tied it all back to one central theme in one word, consent. It's beautifully done, because those really are disparate topics.
Yeah.
And as you were sharing them, I was like, my favorite creators on Substack tend to be the ones who show up authentically as their whole selves, or at least, most of their whole selves, not just writing on one topic. But it is best when you can come up with, there's generally a narrative thread that ties them together, and yours is consent.
Yeah.
That's
I appreciate that.
Yeah, that is a great central spot. And I was thinking about the show and the work that you do, and I was like, I don't know of another physician out there. I can't think of any other person like you. There's generally oh, I'm one of the people who's writing on this topic. But I don't know of any doctor who's tackling this niche quite as you are, as a Gen X aged woman who's addressing women's health and aging, and menopause and hormone therapy and all of those very practical things we need to be talking about more directly, but doing it with such an overtly sexualized, well, not sexualized, but sexual lens.
Yeah.
As I'm not creating porn. I'm just being very direct about who I am and who so many women of this age are. And that doesn't get talked about.
Yeah.
So important. I don't know. Oh, go ahead. Sorry, you first.
I was just going to say, I really appreciate your acknowledging that, because this is something that I've really been struggling with. And I'm coming up on, in 3 days, my 2-year anniversary of being on Substack. And I sort of went into this with the idea of I am going to be, the guru of kink, and I'm going to, be sort of have this authoritative tone and be an influencer or like use Canva to create all the like graphics of like giving people permission to explore their curiosities, right? And over the course of time, I'm like, I really feel confined by pigeonholing myself into like just talking about medicine, or like I'm just going to wear this like white coat persona that's like authoritative, or and also there are a million and one voices on Substack, probably more, talking about just their sexual adventures and ethical non-monogamy, or like dating, or men and women, gender war kind of stuff. I was like, I don't want to niche down into just one thing. Like, I have this voice that is kind of unique, and someone somewhere along the way was like, you are like the Dr. Ruth of this generation. And I was like, that's what, like,
oh
that's
my God.
ultimate compliment, because I want to make sort of relational curiosity okay and normal. And I think it's just like there's a softness to that, and a vulnerability to that, and a requirement to like show up both for yourself and your partner that really is not like, it's not talked about. And so many people are like, you are like burnt out with dating, or they're burnt out with the apps. They're seeking like real connection, and like, how can I, as and one would argue an authoritative like medical voice, sort of like lend credence to that. So it's been an evolving thing, and sometimes it takes courage. And there have been times when I've been like, I publish, and then I'm like, oh God, no. And I unpublish, and then I put it back out there. And so, yeah, I appreciate those who are kind of like working through this with me as I find my own voice on this platform.
My first, one thought is it must be lonely being like, there's no one else doing this, but I hope it's also fun and exciting.
Yeah.
It is fun and exciting to follow along as a reader and someone who's lucky enough to get to be in conversation with you from time to time. I feel that way sometimes as the elder in the room, of like, I am frequently in spaces having conversations where I joke that I'm like, I'm a time traveler, because especially if it's at night, if I'm at a show or a karaoke bar, like in a dark room, I appear a lot younger than I am. If you come look close up at my face, I'm obviously older, but I have this hair, and just being in those spaces, there's just a presumption of youth. And it feels, I don't feel out of place, but there is a sense of like, where are my peers who are still socially curious about doing whatever it is that I'm doing at the time. So it's not, sorry, I'm a little bit, as I'm sick, I'm finding I'm a little bit more tangential than usual, but I hope you don't feel lonely. I'm grateful to you for pioneering. And I also feel like where you go, others will hopefully follow. I mean, I don't know if there's going to be like a physician exactly following suit, but my new presence online is called I Write Out Loud. And it was because someone told me that I live out loud, and it was a huge compliment. And I would pass it along to you of like, you are living and writing out loud.
I appreciate that. And I also want to acknowledge like the age thing, because I talk to so many women in my office, and I'm very comfortable talking about libido. Like, I would like to be the go-to physician when people are like, I want to talk to a doctor about my libido and like what's going on with this. I'm going to go to her. And so that's part of why I'm putting myself out there in the world as someone who's like has a medical background, and also like a gentleness about this. But in my opinion, we don't have to age out of sexuality. Right. Like, and I've got ladies in their 60s and 70s who are like, between my ears, I'm still 35. Right. Like, I don't know how all this time passed. And like, I love talking to those patients, because like they have this wisdom and this perspective, and not just patients, like, close friends in my life, and like older lovers. Right. Like, I just like, there's a part of us within our mind and our erotic imagination that like doesn't know physical age. And, part of what I do is like figuring out how to work within the parameters of the limitations that our bodies put on us as we age,
Mhm.
and how to figure out ways around those limitations that allow us to continue to play and connect if we want to, right? Like, that's not saying like you need to be sexual until the day you take your last breath. If you want to do that, which I do, I'm here to help facilitate that. But I like, ageism is one of those like subtle little things in society that's still
Oh
sort
yeah.
of okay. And I
Oh yeah.
really, like, especially now that I'm working with a lot of like middle-aged and older adults, like clocking my own ageism, not just towards older folk, but also towards little kids. Like, there are a lot of people that are like ageist against youth. And, just the
Hmm.
same way that like I try not to talk to a toddler in a patronizing tone, or a young child in a patronizing tone, and talk to them in a way that's developmentally appropriate. I just want to like, kind of pin the importance of what you just said.
Yeah. Thank you. If you had asked me, in my 20s, what I thought my 50s would be like menopause was never talked about back then, and it was this big scary cliff, and I would have been like, oh, everything just sort of dries up and dies. I have no idea. And
Yeah.
now I have a half story written that's just lingering, like many other of my drafts, of like, hey guys, like, secret, like, menopause is awesome. Once you're through, once you're done, like, everything settles down. And yeah, like
You don't have to
sex
worry about
drive,
getting pregnant.
you no longer have to worry about getting pregnant. You're not at the mercy of a 30-day hormonal cycle that, like, I'm not saying that, like, PMS dictates your life and you become a crazy person, but there's certainly an influence of like where you are in that 30-day cycle that impacts how you move through the world and what
Absolutely.
you have to mask to the world if you're not feeling well or not quite in your right headspace. That all goes away and becomes even. But like like feeling sexual, feeling horny, having a libido, like none of that has changed for me.
Mhm.
And that's been really surprising.
Yeah.
Like, I don't, am I, so I haven't asked you a lot of questions. We've been doing like conversations so far, but is my case unusual, or is, in your experience as a doctor and talking to women about this, is it pretty normal that women are still like, oh yeah, I'm still right here, girl, or am I an outlier?
So it runs the gamut, right? Like,
Yeah.
there there actually, like, there's data to show, and there are charts and graphs that show how common it is for libido to decline in the years leading up to the final menstrual period, which by definition is menopause, and then for the couple of years thereafter. And then the data also shows that libido starts to increase after that. And also, interestingly, testosterone, just like guys, their testosterone like decreases over the course of the lifespan. The same kind of thing happens with women. It doesn't
Hmm.
fall off a cliff at menopause. It sort of gradually declines over time. But in the 60s, you'll start to see an increase in testosterone levels in women. And
Oh,
so we'll talk a little bit about testosterone therapy and sort of like options for treatment of libido. Like, that's where I'm going with this.
yes.
But to answer your question more directly, it is a very common experience for people to have a decrease in libido. So what does that mean? And it looks different for everybody, right? And like, your experience now may look different 2 years from now. It probably looks different than it did 3 years ago. And so this is kind of like, it's a moving target, and it's different for everyone.
Yeah.
So decreased libido is one of the most common, like, we ask about it on our intake questionnaire at the clinic where I work, because a lot of people
Mhm.
experience that, but they won't bring it up unless I bring it up first.
Because
And
people don't think about it as medical. That's just
unless
emotional.
you're a man, it is
Oh,
medical if you're a man. If you have erectile dysfunction,
true.
it is like, the end of the world, and you have 26 products on the market to deal with your erectile dysfunction. But if you
Right.
are a woman, you need to sit down, be quiet, and, just acknowledge the fact that your sexuality is gone, and that's fine. And I wonder if that's why there are so many men, like, we've been treating all these men for erectile dysfunction, but
Right.
not treating women. So men are seeking out younger and younger women to meet their needs, because we as a society and as medicine haven't taken care
Yes.
of women's health. But I'll get off
That
my
completely
soapbox.
makes sense.
Yeah.
No, that totally makes sense.
But there are, at least in the United States that I know of, there are like 3 fellowship programs that specialize in women's sexual health. 3, right?
Okay.
And
That
I
seems
like,
small.
yeah, like
Okay.
this wasn't talked about when I was in medical school, just like hormone therapy wasn't talked about when I was in medical school. So like I've had to go back and relearn it now. And ISHWSH, the International Society for the Study of Women's Sexual Health, is kind of my favorite organization. And it's multidisciplinary. If there are people listening to this and you're a mental health professional, or a medical student, a grad student, a nurse practitioner, a physician, and you want to learn more about this subject, like
Yeah.
go check out ISHWSH, because their conferences are awesome. And there's like toy manufacturers in the convention hall at our
God.
conferences. It's great.
Is it ish, like ISH and then wish? ISHWSH?
ISS, International Society for the Study of Women's Sexual Health, ISSWSH.
ISHWSH. Okay.
Yeah, there's also the International Society of Sex Medicine, and these are international conferences. And I think that they're now looking at having more of those conferences outside of the United States for reasons that are probably evident. So it's a good way to get connected with people who are passionate about this from all over the world. But if you'd like, I can kind of like dovetail into medical workup of libido.
Please. That is my very next question, because I am on HRT, hormone replacement therapy. I'm testosterone curious, but have not explored that at all. And I'm wondering if that's why I still have a libido. So I'm eager to hear your advice, and I'm sure our audience is clamoring for it as well. So zip.
Yeah.
You have the floor.
When someone comes in with a complaint of libido, I think of it as like a biological, psychological, and social elements of these things, right?
Yes.
So if the patient has had some sort of like gynecologic trauma, for example, like they've delivered big babies and have issues with, either urinary incontinence or prolapse, or some sort of like, residual pain, which can either come from the mucosal tissue, it can come from like the skin around the vulva, it can come from musculoskeletal pain if they like hold all their trauma in their pelvic floor and their pelvic floor is very tense. That can, lead to pain, or it can be nerve type of pain, coming from the pudendal nerve, which innervates all of the like tissues around the clitoris, the vulva, the anal canal, and sends those nerve signals to the brain. So question number 1 is the patient having pain? Vaginal dryness can be a source of pain with sex. So treating that with vaginal estrogen is easy peasy. I offer vaginal estrogen to pretty much everyone who walks in my door.
I'm a fan.
Yeah. It can be a game changer. I'm also a big fan of lube, like specifically silicone lube. I'm a big fan of Uber lube, and that's in like any gender, any sexuality, any age, like lube. So question number 1 is like medical history. Do they have any other medical conditions? Do they have blood pressure problems? Do they have diabetes? Do they have MS? Like, are they pregnant, or are they breastfeeding? Are they menopausal? Like, so we take that history and physical exam into consideration. And a lot of doctors, maybe they're doing better at training the gynecologist now, but a lot of doctors weren't properly trained on how to do a pelvic exam, especially on postmenopausal women, and clock what it looks like to have estrogen deprivation to those tissues on exam. Because I have seen it where some patients have actually fusion of the skin over the clitoris, what's called clitoral hood phimosis. And
that sounds so painful.
Yeah, like uncircumcised guys can get it too, where the foreskin basically like fuses over the head of the penis, and you have to like either apply topical steroid or like physically in a procedure take it down. And if that's the issue and we can solve that for the patient, then they're able to experience pleasure again, which then drives their libido. So
Gosh.
history, physical exam, what is their relationship situation like, right? Like
Right.
there are a lot of people, who I see because of, just the age of my patients, where they've been in long-term sexually exclusive monogamous relationships. They've, run a house together. They have domestic responsibilities together. They've raised kids together. It's become companionate, but maybe the eroticism has died over the course of time. And so how do we kind of work with reigniting eroticism, which is a whole other different question, right? There's, I have patients who have recently gone through divorce and they're like, I thought I had no libido. That my libido wasn't the problem. It was the relationship that was the problem. If there's abuse, if there's, substance abuse, if there's unequal division of household labor, if one person feels like a caretaker, all of those things relationally can decrease libido either quickly or over time, right?
For sure.
So you have the relational piece. And, from a pharmaceutical management standpoint, there's a couple of options that are sort of like top of mind for me.
Yeah.
So getting back to your point, when I put people on hormone therapy, many times they're coming in with symptoms like low energy, brain fog, anxiety, and poor sleep, like it just runs the spectrum of things. And for many patients, when I start them on estrogen and progesterone, plus or minus vaginal estrogen, they start feeling better, which means their confidence is increased. Maybe they're, looking after their diet a little bit better. They're going to the gym on a regular basis or like have the energy to exercise. I talk to every single person who walks into my door about their level of alcohol consumption because it literally does nothing good for your health at this age and beyond. So I've had a number of patients who either significantly curtailed or quit drinking alcohol entirely. And those types of like behavioral things lend themselves to more confidence in the bedroom and like an empowerment to ask for what they want. Right.
Yes. I'm sorry. I'm smiling. I'm grabbing all the questions from the comments as they're coming in.
Yeah. Good.
I have to just read this one comment from Rachel out loud. She's our guest tomorrow. My HRT is the only thing that keeps me from killing.
Yeah.
And that just made me laugh. So apologies.
And if you're not feeling homicidal, you might be a little bit more receptive to like play with your partner. So it's important. But yeah, a lot of patients will notice that when they start menopause hormone therapy, that their libido increases in the absence of testosterone or anything else. So it can be a game changer for some patients.
Mine was sorry to jump in and just be all about me. This is not all about me. Brain fog, but joint pain. I don't know if that's very common, but I came in and was like, I can't lift my arms without feeling tired. Like I felt like every joint in my body was on fire. It was weird, but I didn't get hot flashes.
Yeah.
So,
and that's again, like everybody's situation is different. And I've had patients come in who are like, have been through huge autoimmune workups looking for like, like some sort of chronic inflammatory process. I've had patients come in with like rashes, like the mood symptoms are incredibly common. But yeah, I had like a professional acrobat that came in and was like, I'm having trouble training because of like back pain. I put her on hormones and like 3 months later, she was like, I'm
a new person.
I can keep doing the crazy circus stuff I do, which is awesome.
Oh my gosh. Is it okay if I jump in with some questions? Because the chat is popping off and it's great. Thank you guys. I'm going to try to catch all of them. Karen, if I miss them, Karen Marie Shelton is our amazing moderator. Please, I'm going to go through these. If I miss anything, just shout out to me in the chat or text me if you're able to on your phone and I'll try to see them there, because I don't want anyone to feel like they missed their opportunity to ask you questions. So
it's not medical advice. See your doctor.
Perfect. Good for the caveat. And this is a question I've had in the past, or I have as well. When you were talking about lube, someone asked about coconut oil, good or bad?
So I am in general not a fan of putting food on the lady bits. I know that there are a lot of people who are. The issue is that those types of oils can actually, if they enter the vaginal canal, can block the natural ducts, because oil and water don't mix, and our bodies are made of, water. So it can get in and like block the natural ducts, and it can also like change the pH environment, because so much of what's going on down there has to do with pH. And as the estrogen levels decline, you get decreased blood flow, decreased collagen and elastin, decreased lubrication production. And so it allows an overgrowth of the unfriendly bacteria that leads to things like BV and UTI. And when you put oil into that environment and you block your own natural like lubrication ducts, you can change the pH and like kind of put yourself at increased risk for those other things. So I like coconut oil on the skin. And in fact, it's really fun to keep a bottle of coconut oil in the shower. And when you shower with your partner, put coconut oil all over them with the warm water and then slide all over each other. That's really fun. But when it comes to actually like in the canal, you can end up doing some things that you didn't intend to do.
Okay. So if I can, it increases a risk of a woman getting a BV or a yeast infection, UTI, all of which go up with menopause, right? Like, those seem to be very common. Okay.
Yeah, because of the decline in estrogen in the pelvic floor tissues, which is why, I have some patients that I've recommended vaginal estrogen and they're like, meh, I'll give it a try. And 3 months later, they're like, girl, I didn't realize that the garden was so dry until you watered it. So thank you for that. And my partner thanks you for that too.
Sorry. That just reminded me of Bridgerton. Have you been watching Bridgerton at all?
No, I mean, I've seen a few episodes at the nail salon and I'm like, ooh, this is spicy.
It is the best period smut. It is like, it's my, like, I love Bridgerton. But the matriarch of the family, who was widowed many years ago, at one point, her libido comes back, but of course it's Bridgerton, so they should be very proper. And so she and her friend have this whole conversation of like, my garden, but my Edmund and I had a garden we tended, and my garden had died. And she's like, my garden is back in bloom. It's very much the euphemism they use. So I love that you just used it, even not having seen Bridgerton. Next question is, there are a few lubrication ones. Why silicone?
So I like silicone because it has staying power. Is basically it. It's to me, it's like, it's slicker than water-based lube. A little goes a long way and you don't have to reapply it as often. Which is especially important if you're talking about anal play. And I've written about anal play before. I think that sort of like big baddie that's out there is like, don't use silicone lube on silicone toys. So I'll address that too. Water-based lube is important if you're using condoms, because especially like oil-based lube can break down the latex in a condom.
Yes. Can coconut oil do that too? Sorry, just to jump in.
With condoms,
condoms,
like oil can break down a latex condom. So the way to get around that is that you can use like latex-free condoms. Like I have nitrile skin condoms. And as it pertains to toys, anything that goes in anyone's body, I always cover with a non-latex condom. So then it doesn't matter how much silicone-based lube you use, it's not going to actually be on the toy. And of course, like, wash your toys after you play with them and, like get everything off. And those are the ways to get around it. But really, unless you're like putting silicone lube on a silicone toy and then like putting your toys all together and not cleaning them, like, then yeah, you're going to have a problem. You're going to have to replace your toys.
That sounds crusty.
Yeah. And there's also like hybrid lubes out there that I've tried and I really like. It's just that with water-based lubes, you tend to have to reapply them. So Uberlube, like I said, I'm not getting paid to say that. But they also have a relationship with clinicians' offices where they will send your office samples for you to hand out to patients. Again, just sort of like normalizing the concept of sexuality being an important part of health.
Perfect. There was a question about butt lube, and I think this is addressing it. Okay, I just got another question sent my way. We'll get to that one, Karen. Thank you. I think that's answering the question that about butt lube versus vaginal lube. So that's all super helpful. A time or two ago when Lawrence and I had you on air, you had recommended a specific lube, and I don't think it was Uber lube. It was something more precious and expensive than that, I think. I don't remember what it was.
It's pretty expensive, like for a
Okay.
at least here in Canada, about this big. I want to say it's like $48
Well,
retail.
maybe it was that then. Whatever it was, I remember I ordered it, that I was like, if Dr. Amber says this is great, I'm going to get it. And by the time the bottle arrived, which was only a couple days, my relationship had ended and I was so mad. I ended up giving it to my daughter.
Well, yeah, it comes in a little glass bottle, but
Yep,
like
that was it.
It goes a long way.
Yes, it I remember just being like, I should have ordered the toy instead. Now there's no guy. So funny aside. Next question. Let me see. Another question is someone is asking about natural lubricants. Besides silicone lube, what are some natural lubricants? I'm not quite sure what that question means. Do you understand it? Is that asking about like coconut oil or?
Yeah, I think it's the spirit of the question. It like seems to me to be about the same as coconut oil, and like if you want to, I'm again very much about autonomy. You can do with your body as you see fit with the consent of the people that you're involved with. And there are some people that are like, you will take my coconut oil out of my cold dead hands. And, far be it for me to tell those people no. But it's just, it's something to be mindful of, and maybe just recognize that, like, keep an eye out. And if something sort of like, physically comes up that's unpleasant in the area, sort of like associate those two things and maybe think about it next time. But yeah,
it makes sense. I have a few other questions here, and I know we have other topics because I want to talk about the pink pill. That trailer you sent me was fascinating. But a few questions first. If you have had a blood clot, what can you add to your list of tools?
So
as a woman in menopause, I assume is where that question is going.
Yeah, blood clots are, it really depends on the history of the blood clot, right? Like, was it an unprovoked blood clot? Do you have a family history of a clotting disorder? Have you had a hypercoagulability workup? Because I have patients who have a history of blood clot and they're on hormone therapy. So this is my strategy. Let's say, and also oral birth control pills increase the risk of blood clots. So, like, I'll give you an example. I have a patient who had, while she was on birth control pills, she went on a long international flight, which also puts you at increased risk of blood clot. She got a blood clot in her leg. And this was years ago. And so she wanted to be on hormone therapy. And, we talked about risks and benefits and, the biomechanics and all of this stuff.
Yeah.
So we did a hypercoagulability workup, because to me, this is a provoked blood clot. Just like if you're immobilized in the ICU for 5 weeks, you get a blood clot. That doesn't mean you can't be on hormone therapy. It means we need to do our due diligence to make sure that you're not at increased risk of this, again, from a genetic standpoint. So in both of those cases, I did the hypercoagulability workup. Nothing came back as being, increased genetic risk for these things. I was like, I think you had this blood clot for these specific reasons under these circumstances. Transdermal estrogen has been shown not to increase clot risk. Neither does oral mechanized progesterone, which are the bioidentical forms of hormones that I use and prescribe in my clinic. And so for those reasons, again, we have a conversation about, like, I can't tell you for 100% certain that you will never, ever get a blood clot again. I can tell you that your risk based on this workup that we've done is not increased from a genetic standpoint, and that the products that I'm proposing putting you on does not increase your risk. So with those things in mind, do you want to try and see if the benefits of being on these medications for you outweigh the, theoretical risk of some future blood clot? And if the answer to that question is yes, then I'll proceed. And of course, I document all this stuff, but Canadians are like less prone to suing their doctors than Americans are. Americans love to sue doctors. But again, that, due diligence, informed consent, those types of things. So if
Yeah.
you are at, if you do have a genetic increased risk because of a positive hypercoagulability workup, then that's another question. And there are things like phytoestrogens, just like with people who have breast cancer, there are, phytoestrogen kind of things like vaginal moisturizers. Gynotrof is one that I recommend on a regular basis. Other sort of like non-hormonal things that you can do. And the Menopause Society, the North American Menopause Society, actually has a white paper that's, like goes into detail on non-hormonal options for menopause treatment for those patients who either because of blood clot risk or cancer or whatever other reason can't be on hormones. And I would invite you to take a look at that paper. And if your doctor is open to it, give your doctor that paper and the two of you can discuss it together.
Great answer. And it leads into the next question, which is, I think I can even take this one. Is there a breast cancer connection to HRT? Look, I'm like the volleyball, like lob it over the net.
Yeah. So the Women's Health Initiative was a study that was done in, I want to say like the 90s. The data was released in the early 2000s, and it was a very well-intended study. I'm not one of those people who's like, this study sucked and it destroyed women's health. Like, the case that they made was overhyped in the media, if you can imagine such a thing.
Weird. That never happens.
Yeah. Now that we are going back and looking at the data, basically what they found is that with long-term use of combined estrogen and progesterone therapy, that there was some small increased risk in breast cancer. And it was like 6 per 1,000 patients, like over 5 years. I might not have the statistics right on that, so don't like cancel me for my, but there is a small increased risk of breast cancer. However, the products that they used during that study were Premarin, which is a synthetic form of estrogen derived from pregnant mare's urine, Premarin, and medroxyprogesterone acetate, which is the active component of Depo-Provera. And we don't use those products anymore. So we are kind of extrapolating from that historical data increased risk of breast cancer, but that increased risk of breast cancer is the thing that people latched onto, and cardiovascular disease. But now that we're going back and reevaluating the studies, we're actually seeing that if we start people on hormone therapy within 10 years of their last menstrual period or before age 60, appropriate candidates, right, that it decreases all-cause mortality, decreases the risk of cardiovascular disease, definitely decreases the risk of osteoporosis and fracture. And for many people, improves their quality of life, improves their libido, improves their relationships, their performance at work, their brain fog, their mood, hot flashes and night sweats is the drug of choice for that. So we're weighing this, potential increased risk of breast cancer against all of the other benefits that hormone therapy provides. And again, like that's the question that I ask patients, like, is this, given your circumstances, is this a risk that you're willing to take? And do the benefits outweigh the risks for you? And that's an ongoing conversation because the risk may outweigh the benefits for you now, but 5 years down the road or 10 years down the road or 15 years down the road, we'll continue to have that conversation. So there was a paper that I found because a friend of mine's undergoing workup right now for a BRCA gene. And there was a paper that came out recently that showed that even patients who have the BRCA gene, like I'm not super familiar with the data right now, but we're even starting to reevaluate whether patients who have a BRCA gene should not be on hormone therapy. So we as a medical community are looking into that, again, because of all of these other benefits that hormones provide long-term.
Yeah, that totally makes sense. I've got one more question and then we can shift topics. And that question is, about red light therapy as an option to ease menopause. Is that a thing?
I don't know enough about that to have an opinion that you should care about.
Excellent answer. It is refreshing when someone can say, I just don't know about that. Fantastic. If you all do have more questions, please feel free to put them in the chat. Where should we shift the topic now? I know you had some questions for me. Yeah, you could. Do you want to ask me questions? Should we talk about? I do want to talk about the pink pill at some point because I had no idea that that existed until
Yeah.
I watched that trailer. But I know you also had questions for me. You are my guest. Where would you like to steer this conversation?
So why don't we talk a little bit about testosterone and the pink pill and kind of wrap up with the idea of boy sober dating apps and connecting in real person or in real life versus online.
Yeah.
Does that sound good?
It sounds great to me. And I am able to go a little bit over if you are.
Okay.
If you are not, that's okay too. I know you're, a doctor, and there are probably patients
I have
clamoring to
patients
see.
starting at 9. So,
Okay.
um, so as
So the pink pill.
yeah, the pink pill. And I also want to like put a little pin in testosterone too. So testosterone
Okay.
for some women, testosterone is FDA and Health Canada approved for the treatment of hypoactive sexual desire disorder in postmenopausal women. It is
Okay.
approved and indicated for that. So I get questions about testosterone all the time. The New York Times ran a huge article about like how it's making women like run faster, jump higher, hump couches, and like changing their lives. So everybody's coming in like asking about testosterone. I'm comfortable writing for it, but with a couple of caveats. So
Yes.
the only testosterone products that are like FDA and Health Canada approved in North America are for men. And those products are dosed for men. So when we're talking about giving those products to women, we're trying to give, and they're usually like a gel, right? So
Yes.
we're talking about giving it at like a 10th to a 20th of the dose to treat women. And that's a very like imprecise way to measure these products, which have significant side effects in some patients. So some patients like they'll start to lose the hair on their scalp, which I don't know any woman who wants that. Increase like facial hair, body hair. In the case of like pellets and injections, for example, if you overshoot the dose, you can have irreversible voice changes that deepen your voice and enlargement of the clitoris. And those things are irreversible. And so if you think about the thing that trans folk on testosterone would want, most cis women don't want those side effects. And so the dosing of these products is very important. So with that being said, when someone comes into my office and is like, my libido is low, I don't have any energy, like I heard testosterone is going to do all these things, I want to try it. My starting point after having that side effect conversation is let's measure and see where your level is now, because my goal is to keep you in a physiologically normal range for women. And the measurement is different in the United States than it is in Canada, but I have this narrow window that I'm trying to keep people in. And so
interesting. Is it higher in the US or in Canada?
Well, it's just we use the SI system there, and they use standard measurements. So I don't want to throw a number out because someone in the United States listening might just be like, oh, my number is this and it's supposed to be that. And we use different numbers in Canada.
Makes sense.
Yeah, my goal is to keep them in a physiologically normal range and minimize side effects. However, I've had patients who are in the physiologically normal range and they're like, nope, doc, I put that aside. I started noticing my hair falling out. We're done with this. And I have some patients that are like way over the mark. They feel like $1 million. They haven't had side effects. And they're like, I don't want you to take this product away from me based on a number on my labs. And again, that's where the consent conversation comes in. That's where the autonomy comes in. And so for many patients, especially postmenopausal, they'll find that testosterone works. I have some perimenopausal patients that, again, I have this conversation with. They want to try it, we'll do it. And if they like it, we'll keep going. And I'll also say, I'm on testosterone. It made a big difference for me. Okay. So for perimenopausal patients who are struggling with libido and maybe their testosterone is within the normal range or they don't want the side effect profile of T. So flibanserin is an oral medication that was actually, and there's a movie that just came out about this. Full disclosure, I went to a screening on it and the filmmakers were there at the screening here in Vancouver last weekend.
Amazing. And that's the pink pill. That's the trailer.
Yeah.
Can I say the tagline because it's so good?
Say it.
At the end of the trailer, it says, "Sex, drugs, and who has control." And I was like, "Oh God, that's good." It's a
Sex is
really
all
good.
about power. I'm going to write an article on that too. But
Yeah, you should use that as the header or the subhead. It's brilliant.
it is brilliant. So flibanserin is an oral medication that was originally investigated as a treatment for depression. It acts on the dopamine receptors in the brain. So what they found in the study was that it didn't help with depression, but the patients who were in the treatment arm using this medication found that their libido improved, which I am less depressed when I'm having a good sex life. So
Sure.
but it doesn't technically treat depression, it treats libido. So the little company that developed the drug went and fought really hard for FDA approval for this medication. And that's what the movie's all about is, there are all these products on the market for men, but none for women. And the data shows that it improved libido to the point where people went from having 0 encounters per month to 1, which, the people at the FDA were like, it's not like that's a negligible positive result and there can be side effects and all this stuff. But like when you talk to couples who are in long-term sexless relationships, which I too have been in, they're like, I would love to be connecting with my partner once a month. Like that's so much better than 0. And so that again, autonomy comes in. And so
it does. And also is the frequency of times doesn't have to do with how you feel in your body necessarily either.
Yeah, exactly. There's a confidence with how one moves through the world.
Yeah.
That comes with an active libido, an active sex life, just that playfulness and like nourishing, like somatic experience of being physically in contact with another person, right? Especially if it's the person that you love and have like committed your life to. Like 0 to 1 can make a big difference in relationships. People get divorced over this, And
were they tracking like masturbatory behavior too? Or were they just, the only success metric was like PIV sex with partner? Anyways, I don't want to derail the conversation.
I don't know the data like well enough
Yeah.
to be able to say like thoughts of eroticism or like masturbatory behaviors, but I'm sure that the paper's out there. But that medication is on the market in the United States and Canada. I don't know where else. But it's an option for some patients. And so if that's your thing, just be aware that, testosterone, yes, is an option. Flibanserin, yes, is an option. There's another medication. It's actually not on the market in Canada, but is in the US called Vyleesi. And this is an on-demand injection medication. So it's not a pill that you have to take every day, like the pink pill. It is an on-demand injection. Like I'm going to go, like we're going out tonight. We've dedicated this weekend together. I'm going to use this thing for this period of time. And so you don't have to commit to taking a medication every day. And yeah, that's Vyleesi. I wish we had it here in Canada, but it's not approved yet.
Wow. So that works more. Sorry, I'm putting the trailer for, I keep grabbing the wrong URL. Sorry, you guys. Where did it go? That sounds like it works more like Viagra, where it's a one-time, you use it and then it fades versus a sustained medication.
Yeah, but the dosing mechanism is the same or similar.
Okay. Yeah. Fascinating. I have literally never heard of it. I mean, maybe because I didn't go into my doctor complaining about it, but you would think in the zeitgeist it would be out there and known by women our age.
I think the whole point of the filmmakers making this movie was that of like, when Viagra hit the market, it was like this bazillion-dollar drug and everybody was talking about it, right? And you had this whole marketing campaign of these beautiful women on camera talking about how erectile dysfunction is normal and you can treat it so that you can
right, of course,
and all that stuff. Like it was a big deal. But when this little company developed this drug and like tried to bring it to market, the little company got bought up by like a big pharmaceutical company who didn't follow through on the marketing of this product. And so it's sort of like faltered on the market. And so then the little company, this is what the movie is about, like went back and sued the pharmaceutical company for breach of contract because they were like, we worked really hard to get this product approved for women because it's important. And you guys dropped the ball on the follow through and marketing. We want our product back. And so they like the little company reobtained the rights to that medication in 2025. And now I think they're like really pushing from a marketing standpoint to get this thing into the hands of the women who want it and need it.
Oh my God. Please say that it was the small company that was run by women. Because
Yes.
the trailer was all women.
Yeah.
Of course it was. Of course
Little
it was.
a powerhouse like woman is running this company. And I was like, yes,
Yes.
girl, wear pink to the FDA.
Right? Question, where can one get this medication? I assume it needs a prescription from a doctor.
Yeah, it needs a prescription from a doctor.
Talk to your doctor about. And another question is to please spell Salisi.
Oh, Vyleesi. So the injection medication, let me Google it real quick. Sorry.
Okay. Yes, and I see Carrie is saying, me and my women gym friends have no trouble talking about it, and it helps us to talk to resistor providers about this stuff. You're so right, and it sucks that we women have to like educate our doctors so often. I don't. I'm really lucky that I'm in Seattle. I have a naturopath first put me on HRT, and my primary care physician is a menopausal woman too, and it's like, girl, yes, there's not a problem here. But I hear so many women say, I had to bring in the study that shows this is okay and like convince doctors. But no one proactively told me about it. It was actually my guest on the show last week, Christy Coulter, who's a writer here in Seattle and a friend of mine, who was championing pretty hard on Facebook of like, these are safe to take for most women. The quality of my life is immensely improved, and that made it okay for me to ask like, hey, I think this might actually be a good idea. So women talking to other women tends to be what changes the world.
It's true. So the spelling of the medication is Vyleesi. So that's the injection dopamine medication. And yes, I have patients who come into me and they're working with naturopaths. And one of the things that was like conditioned into me as an American, like allopathically trained, like allopathically trained doctor was like, naturopaths are full of baloney and, blah, 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 whatever. And like some of my closest friends here in Vancouver are naturopaths. Like I am pro psychedelic assisted psychotherapy, right? Like I would rather like take things away from your medication regimen rather than trying to medicate a problem that needs to be addressed through lifestyle interventions. And so like, that doesn't make me maha or like quackery or anything like that. Like we need to learn to like be okay with uncertainty and like recognize. And when I say we, I mean we as the medical community, like realize the mistakes that we've made in the past that has led to this like, profound public distrust. And so when patients come into my office, I'm like, this is what I'm uncertain about. Like, I think that this would be okay. Like, and I've had patients who were like, can you track this paper down that talks about dementia risk and starting hormones in women over 60? Like, can you track this paper down and can we read it together and talk about my risk? And I actually, like, because the whole paper wasn't available online, I reached out to the author at Harvard and was like, will you please send me this paper? My patient in Canada wants to discuss this with me. And the author was like, more than happy. Absolutely. We get around the fees of the publisher and like puts the power back in the hands of me and my patients. And, that's the demand on us right now. It's like, we have to keep learning. We have to keep like being okay with uncertainty and having an honest communication with patients. That's what they want, at least in my experience.
Your patients are so lucky. I mean, if you were close by, I would be like, 100% I'm going to see you. Although I've been seeing my primary care doctor, I've been seeing her since the 90s and I love her. And I know she's going to retire soon, and I never get to be sick again, I guess, because I couldn't replace her. We have this long-standing relationship. I missed a question that Karen just texted me about how long do hot flashes last? And I'm not sure if you mean duration in your life or how long does the flash itself last? I assume it means duration in your life.
Yeah. So vasomotor symptoms is what we're talking about, hot flushes and night sweats. And they originate actually from the neurons in the brain, but they affect the vasculature, if that's obvious. So vasomotor symptoms can last like 7 to 12 years on either side of the last menstrual period. So for patients who can't be, like, the drug of choice for hot flushes and night sweats, vasomotor symptoms, is estrogen. And I put people on estrogen on Wednesday, and those symptoms are gone by the weekend. Like,
It's
that,
incredible.
it's the drug of choice.
Yeah.
But for patients who, for blood clot reason, cancer, whatever, can't be on hormones, there's a medication called Veoza, fezolinetant. And this is an oral medication that acts on the KNDy neurons in the brain, which are the things that trigger the hot flashes. And I have patients who aren't on hormones and are on that medication, and they're just doing beautifully on it. The thing with that medication is that because it is processed in the liver, you have to keep an eye on liver enzymes. And there's a protocol that you have to go and get your liver enzymes checked every so often to make sure that it's safe for you to continue using that medication. But yeah.
And I hate to do this to you. There's another request to spell that medication. Are you able to find a link or something that we can share in the chat? Because I already don't remember what you said. It was a long name. We have a comment here from a fellow physician in the chat. As a physician, I think you are an amazing speaker. This message gets out. So,
thank you.
Yeah, to everyone in the chat, like I love when the Daily Whatever show is interactive and engaging like this. So thank you guys for coming, and thank you for coming forward with all of these questions. I know they can be hard to ask, but yeah, it's amazing to have you here as a resource, Dr. Amber, and to be sharing your expertise with us.
Thank you. I'll spell Veoza for you. It's VEO.
Oh, okay. Hold on. Let me come over here. VEO.
ZAH.
Oh, okay.
Fezolinetant is the generic name.
Okay. Uh-oh, my chat froze. Hang on. I gotta hit refresh, you guys. That means it's a good chat and it's active. And it means Substack really needs to get their act together because it happens almost every live. But I'm like, yep.
Lives together. I so wanted to talk to you about boy sober and online dating and kind of alternatives that I'm seeing, because I'm seeing little communities pop up around here of people are getting tired of dating apps, but I feel like that's a whole other conversation.
It is. I feel like I looked at the questions you sent me beforehand and I was like, oof, these are going to be big conversations. I would love to get you scheduled to come back on again and talk about this stuff. Can we do that? Because I do feel like we would have to go way over. It's already 2 minutes till the top of the hour to talk about my man sober experience from a couple of years ago. And I would love to hear your online dating alternatives. And I'm sure, I am certain that would have a lot of questions and comments as well. So how about maybe next month?
Yeah, let's do it.
Come on back and let's have this conversation, because these are topics that would need to be talked about. I mean, I write about this kind of stuff a lot. I actually have, I finished another article last night, which I just released a new one on Monday. So to have 2 in 1 week is that's a lot for me. And this is one I've been working on a long time, and it's around the concept I'm seeing so much of on reels and think pieces online of the avoidant man, attachment theory, the avoidant attachment man and the anxious attached woman. And I have so many thoughts on this, and I feel like it would pair really well with a boy sober online dating alternative conversation, because the TLDR of my story is, well, there's actually too many things to dive into. It's complicated, but the difference between you have an anxious attachment disorder, or as part of your identity, versus the way he's behaving is making you anxious, and that's a signal you should be paying attention to. And we women should stop pathologizing it and ourselves and trying to fix something, when in actuality the anxiety is a very natural response to some of the dating norms that exist.
I so want to read your article, and I'll I know we're at the top of the hour, so I'll punctuate my statement with this. So Dan Savage, as you know, is my he was the source of my sex education from like 17, and I grew up in a very like religious, like fundamental Southern Baptist family. Like you just didn't talk about sex, right? So like I learned everything I know from Dan Savage and Ishwish. But he's
from Seattle. I've been listening. You need to be on the Savage Love cast. I loosely know him. We're going to make this happen.
I would love that. But he talks about how like just saying I have an avoidant attachment style doesn't absolve you of the responsibility to do something about that. Like you can't just walk through the world and be like, I'm avoidant, and like expect the world to like, or the people that you partner with or the people that you care about to like yield to your, you know,
identity,
security, like identity stuff. Like you need to like actually do the work to figure out the root of that and overcome that, because you know you can't be a good partner if you don't have a secure attachment style. And that doesn't mean you need to go into the therapy industrial complex. Like there are ways to do self-reflection and get to the roots of your own insecurity that makes you show up better for a partner. And so I also have like big opinions on the whole idea of like, this label is my identity. Like I am depressed. Like maybe depression is upon you because of a certain set of circumstances. And maybe you do need to, you know, you're dealing with grief or loss or, you know, like stress or whatever. But like, that doesn't mean that you are this depressed person for the rest of your life. You know, like labeling oneself as this thing, I think is very limiting. And
yes. And I'm doing this dance, Amber, because you're like, we're so aligned. So I'm going to give you a sneak peek of one of the sort of pillars of this article I'm writing. Did you study Spanish, or do you speak any Spanish at all?
Muy poquito.
See, I studied it for years. I'm super not bilingual. But do you remember in English we have one state for to be, right? Is, we are, that's to be is our only passive verb like that. And in Spanish there are two. There's ser and estar, which makes it really hard for English speakers to wrap their brain around it. And that means that people who speak Spanish as their primary language not only need to learn when to use each, but it means that they have a different way of thinking about the two states of to be. And at the high level, ser is speaking to what is immovable. You know, I was about to say I'm a woman, which we won't get into gender identity, but like things that are fixed. And estar is temporary state. I am hungry. I am sad.
Cold, wet.
Yes. And so Sarah and Estar is sort of one of the guiding principles of this article of like, if you say I am anxious, it is Estar. It means I am responding to a situation that's causing anxiety in my body, and I'm letting you know I feel it. Where if it's Ser, it's I am anxiety. And it becomes a part of you that is immovable. And there are people for whom it is a chronic, lifelong condition that they have to manage. That's 100% true. But that's not typically the case when we're talking about dating.
Right.
And it's important to distinguish those things. And then it goes into how we sort of glamorize the avoidant man. He's Mr. Darcy, and he's brooding, and he's been hurt a few times, but you know, he just needs the right woman to unlock him. Hell, it's the plot line of every season of Bridgerton, effectively. He's a rake, and the right young virginal ingenue unlocks the key to his heart, and then he's saved. Where for the woman with anxiety, she's damaged. She has baggage. It's pathologized.
Daddy issues, right? Like,
yeah, of course. It's not the fact that it's not the fact that we have, you know, been up against very trying circumstances, often around consent,
patriarchy,
and patriarchy. So yes, I'm going to share a draft with you today, because it's not live yet. I finished just a draft. I think it's done, but you know, I like to let it sit before before publishing, and it'll probably go up next Tuesday on I Write Out Loud. But this we're going to schedule time to talk about this individually, because this is a big topic. And I love that you love Dan Savage, and I'm now like, we are getting you on that show. You should absolutely be on Savage Love. Like,
I would love that.
oh my God, I would too. I would be, I usually listen, like when I'm at the gym, I listen. I haven't been there in weeks because I've been so sick, but I'm on my little elliptical machine listening to sex talk. It's like my funny subversive act at the gym.
Yeah, totally. I listen to Dan Savage when I need a break from all of the things. He had this, like at the top of a show recently, was talking about how people in Minneapolis were throwing used dildos at ICE. And I was like,
they were.
Yeah, it's hilarious.
I heard that one.
That's just the kind of news story out of the United States that I need.
Oh my gosh, I bet. Okay, so I'm going to write to you. I'm going to send you the draft. We're going to get you scheduled for your next one, because we have to dive in on all of these topics. And I'm going to regrettably say goodbye, because it's you're coming up on needing to get ready for your patients, I am sure. Thank you to everyone who's joined us today. This has been an amazing conversation. I will get the recap up shortly so that you can all benefit from Dr. Hull's words of wisdom. And yeah, Lawrence and I will be back for the Daily Whatever show tomorrow. We've got Rachel from This Woman Votes, who's been an active member of the chat today. She's coming for Fucked Up Friday, where we're going to dive into the news of the week, make it our weekly friendly competition. And yeah, have a wonderful day, everyone. Love you, mean it.
Thank you. Bye.
Bye. And I hope Lawrence is still in the background so he can